We know historically that patients, their degree of response to traditional or conventional chemoimmunotherapy predicted how long they stayed in remission. Outside of transplant, we generally think of CLL as not curable, but the depth of response often correlated to how long patients stayed in response. There's the traditional markers of response like partial and complete response, but then there's something we term measurable residual disease, meaning even beyond a complete response, can we, by sensitive flow cytometry or sequencing methods, identify any residual CLL? And it's been known for years that patients that achieve a CR and are MRD negative have longer response durations from traditional chemoimmunotherapy. As we started incorporating novel agents into the treatment, we had to re-examine how traditional markers of response played a role in counseling patients. For example, with ibrutinib, many patients don't achieve a complete response. However, they can still have long duration of response and clinical benefit. Now I think we're starting to shift and recognize that though as monotherapy that's true, and ibrutinib in the front line, for example, Dr. O'Brien has presented that only up to about 29% of patients with years of follow-up on monotherapy with ibrutinib will achieve a complete response. When these drugs are used in combination, we're seeing higher CR rates and now undetectable or unmeasurable or MRD negative, with all those terms meaning the similar thing. There's a couple things in CLL to keep in mind. One is what methods being used and what the cutoff is. Often we call MRD negative less than 1 in 10,000 cells. Not all centers and places can do the testing. You can't just send regular flow cytometry for diagnostic. It has to be high level of collection that you can say patients are MRD negative. But with venetoclax, that we'll hear more about in the front line, but in the relapsed refractory that's been presented with the Murano study, where patients were either randomized to BR or VEN-R, there was a high rate of MRD negativity, and when patients stopped the drug at 2 years, those that had undetectable, unmeasurable, or MRD negative, many of them are still with routine monitoring MRD negative. So we're hoping in the front line those rates can be even higher, and finally maybe be able to take the best of both worlds, which is what a treatment end response is in patients having fixed duration of therapy. Just getting back to what I said originally, though, that might not be the goal for every patient, particularly maybe for older patients or patient with comorbidities. But I think in CLL, the MRD negativity data that we're seeing allows patients potentially to have fixed duration of treatment.